Good afternoon. My name is Silke Gillessen. I'm a medical oncologist from Switzerland, and I will talk about the highlights of prostate cancer 2025. Here are my disclosures of interest. And I will talk about the AMPLITUDE trial in the metastatic hormone-sensitive setting, also shortly about PSMAddition and CAPItello-281, then also about the stopgap analysis ARPI, the NSARAT trial in high-risk localized disease, and the Canadian Cancer Trials Group PR21 in metastatic castration-resistant disease. I'm going to start with AMPLITUDE that was presented by Gerd Ottar at ASCO 2025. And it's really an exciting trial because it's our first trial that tries to give personalized treatment in metastatic hormone-sensitive disease. So all patients included in this trial had an alteration in at least one HRR gene. You see here the genes on the slides that were allowed. And these patients were randomized 1-to-1 to either ADT Abiraterone plus placebo or ADT Abiraterone plus Niraparib. The primary endpoint was rPFS. For the publication, the patients were divided in subgroup, either BRCA or something that was called HRR effector, that were also patients including the BRCA alterated patients, and the ITT population. Baseline characteristics important. These were a lot of de novo patients, as you see here, more than 85%, and patients with high volume disease, 78%. 16% had prior docetaxel in the mHSPC setting, and 55% of the patients had a BRCA alteration. And here you see the results. So this is very, very impressive. The primary endpoint, rPFS, was positive, was met. In the BRCA-mutated patients, you see a hazard ratio of 0.52, whereas in the ITT population, you see a hazard ratio of 0.63. Written in the publication, the rPFS, the hazard ratio of the patients who did not have a BRCA alteration, was 0.81. I think this is an important number. Secondary endpoint here, time to symptomatic progression, very important for patients. Again, statistically significant, better for the patients with BRCA alterations with a hazard ratio of 0.44, but also in the ITT population. If you look at the safety profile, there were more grade 3 or 4 treatment-related adverse events. And you see here 30% in the placebo arm versus 56% in the Niraparib arm. These adverse events were specifically hematologic, as you see here, but also cardiovascular. In the same setting, and also with the idea to personalized treatment, was the Capitello-281 study presented by Capivasertib at ESMO 2025. These patients were all PTEN-deficient with at least 90% or more of the cells by immunohistochemistry. And all patients were de novo metastatic, 75% high volume. They were randomized 1-to-1 to ARPI plus ADT plus placebo or ARPI plus ADT plus Capivasertib. The primary endpoint again was rPFS. Also here, the primary endpoint was met with a hazard ratio of 0.81. And if you see and look at the PTEN score, it seems that patients with a PTEN score of 100%, 99% have more benefit than all randomized patients. Again, this was a post-hoc analysis, but I think it's biologically quite plausible and also very interesting. Also here, if you look at the adverse events, more adverse events in the arm with the ACT inhibitor, 67% grade 3 and more versus 40.4%. Again, in the same setting of metastatic hormone-sensitive disease, also PSMAddition, we have waited quite excitedly for this trial to come out. So this is now patients again with metastatic hormone-sensitive disease, but with one or more PSMA-positive lesion on a gallium PSMA PET. And these patients were randomized to ADT plus an ARPI versus ADT plus an ARPI and 6 cycles of lutetium. This is a different patient population. Only 50% of the patients were de novo patients, 68% were high volume. And what you see here, again, rPFS as a primary endpoint. The primary endpoint was met with a hazard ratio of 0.72. And you look here at the incidence of adverse events. If you look at the ones that are related to any study treatment, grade 3 or more, 12% in the ADT plus ARPI arm versus 22.7% in the arm where lutetium was added. As a short notice, again in metastatic hormone-sensitive disease, there was a meta-analysis, systemic review of the ARPIs in mHSPC based on individual patient data from the stopgap group. And you see here the ARPIs give a clear benefit on overall survival and also clear benefit on PFS. These data were presented by David Fisher at ASCO GU 2025. The effects on PFS were not dependent on volume of metastasis or timing of metastatic diagnosis and other factors. But what was really interesting to see was when you looked at age group, patients with younger age, less than 75, had a very similar effect of abiraterone or lutamides, either on PFS or OS. And it seems that patients with older age group, the 75 plus years old patients, have less improvement of PFS and no improvement of OS when you use abiraterone versus the lutamides. So we are still collecting more data for these analyses, but I think this is quite interesting data because the missing data is in reality on the lutamides and not on the abiraterone. If we switch gears and go to high-risk localized disease, again, NSARAT, really a trial that we awaited from the ANSWER, the Australian study group. And this trial was also presented at ESMO 2025 by Paul Nguyen. And you see here, these were all localized high-risk prostate cancer patients treated with ADT and radiotherapy, either plus enzalutamide for 2 years or a conventional non-steroidal anti-androgen for 6 months. And the primary endpoint was metastasis-free survival by conventional imaging, and as you see here, no difference. This is quite interesting because we have the STAMPEDE data for very high-risk patients where the addition of abiraterone was beneficial. And what we have, I think, learned from NSARAT is that patient selection really matters for treatment intensification. The NSARAT benefit in patients with clinically N1 disease is quite consistent with the STAMPEDE data. but in general, ENSERAT enrolled more favorable risk patients. We go last but not least to the Canadian Cancer's Trial Group PR21 study in patients with mCRPC. You see here, this was an open-label randomized phase 2 trial. All the patients were chemotherapy naive and progressing after one ARPI. So very similar to PSMA, the PSMA-4 setting, but the patients were fit for chemotherapy. The patients were randomized 1-to-1 to either docetaxel 75 milligrams per square meter every 3 weeks or to lutetium 6 cycles. And then at progression, they could do crossover to the other drug. You see here the primary endpoint, rPFS in the ITT population. It was a superiority trial with the hypothesis that that lutetium would be better than docetaxel. But you see here no difference, no statistical significant difference for rPFS. Docetaxel in red here, you see numerically even had a longer median rPFS of 10.7 months versus 8.6 months. The adverse events were, as you expected, either from docetaxel or from lutetium, but they were more frequent grade 3-4 treatment-related adverse events in the docetaxel group, 34% versus 30% in the lutetium arm. The interesting result is the overall survival. Here you see a statistically significant difference, but in the favor of docetaxel in red again. So the median overall survival for docetaxel was 18.2 months versus 14.3 months in the lutetium arm. I think that's quite interesting data. Again, it was not a primary endpoint overall survival. It was a phase 2 study, but interesting data. So what has really changed practice? So personally, I think AMPLITUDE, the addition of niraparib to ADT and abiraterone is a potential option for patients with mHSPC and personally for me with BRCA mutations. FDA has approved the combination for BRCA2 mutations. EMA has not approved this schedule yet. So I think very interesting. So of course we have to await also the OS data, but really, really good benefit for patients with BRCA mutations for rPFS. The STOP-COP RP meta-analysis, I think, showed us that there is a clear benefit of addition of an RP to ADT for patients with mHSPC for rPFS and OS. And since we know from real-life data that still a lot of patients with mHSPC receive only ADT, I hope this is really going to help that this doublet is given to most of the patients. And what we also learned, I think, that age may be an important factor to consider the choice of an RP. So personally, I think the data is quite convincing. It's not published yet, but quite convincing that abiraterone may not be the ideal RP for patients who are 75 years or older, even if, of course, chronological age is not always the best factor to use. And I have to say I have a bias because I'm a part of this STOP-COP analysis. Then from ENSERAT, we have learned again in an academic trial, we have learned that not all patients with high-risk localized prostate cancer need treatment intensification with an RP, and that patient selection is really key. And from the PR21 study, we have learned that OS was significantly better for docetaxel versus lutetium in patients with mCRPC after an RP, at least for the population of patients that they have selected. And what I think that we really need to overcome chemophobia, because really some patients, fit patients of course, seem to profit from taxanes. So what is coming in 2026? We will have longer follow-up from AMPLITUDE, from CAPItello 281, and from PSMAddition. And I think the books are not closed for these trials. So I think it's really interesting. It will be really interesting to see what's going to happen with longer follow-up, specifically also for overall survival. We will have more data about PARP inhibition for patients with metastatic hormone-sensitive disease. TALAPRO-3 is coming with ENSA plus minus talazoparib, and EVOPAR is a study, ARPI plus minus saruparib. There will be hopefully more data about treatment intensification for high risk or very high risk localized prostate cancer, ATLAS, DASL-HiCap, PEACE-2, and very interesting, I think personally, PROTOS, because compared to all the other trials that we have discussed, it's not radiotherapy, not in combination with radiotherapy, but with prostatectomy. So I'm really looking forward to seeing the results of this trial. And then, of course, I'm looking specifically forward for APCCC 2026, where we will discuss all this new data that has come in 2024 and maybe also already in 2026. You see here our panel. It's like really fantastic. It's the biggest panel we ever had for the Advanced Prostate Cancer Consensus Conference. And we have many open questions, and we really would like to discuss all of them. We have finished the questions. There will be a lot of questions for all the topics we discussed also today. And if you're interested in the management of prostate cancer, you should really register on www.apccc.org. Hope to see you in Lugano, end of April until the 2nd of May. Thank you very much for your attention. And again, hope to see you in Lugano.